if they're having a chest pain emergency, even with a patch on, they can still take the sublingual. It's going to be safe. Go. All right, cool. For a patient who's taking a statin medication. All right, first question. What is a statin medication going to treat?
Cholesterol.
Yeah, hypercholesterolemia, high cholesterol. They're taking a statin. Which one do I need to report to the physician? Which is code for which one of these is bad? All right, patient takes the medication with food.
I can take it with or without.
Yeah, so there's only one statin that has to be taken with food, and what is that one?
Cap starts with cap.
Well, the cap is not a statin. Captopril, you're thinking there is a relationship with food. One, it's not a statin, and that's the wrong relationship. Lovastatin. Lovastatin loves food. So lovastatin is my only statin that I have to eat with. All of my other statins, food doesn't matter. Eat, don't care, doesn't matter. So if my patient wants to take it with food, that's fine. I don't need to report that. We said if the patient's on a statin to lower their cholesterol, we need them to maintain lab appointments. One, to know if the cholesterol med's working, to see if their cholesterol decreases, and two, to make sure that their liver is fine. But look how this is worded. They rescheduled it for 2 days later. Does that mean they're coming in?
Yeah.
Yeah, it means I'm busy today, but let me come in 2 days from now. They're still coming in. That is perfectly acceptable. Patient wants the medication at night.
That's when you're supposed
When do we take our statins? At night. So good. Good patient. Good patient. I don't need to tell the doc the patient's doing the right thing. However, what is my most common side effect? My statins.
Muscle weakness.
Muscle weakness. Well, why am I going to tell the doc that they're having a very common side effect? We know that it causes weakness. Why do I need to tell the doc about that?
Is that hypoglycemia, right?
No, it's not potassium-based. Statins shouldn't affect my potassium. Exactly. So there is that rare, potentially very dangerous side effect of rhabdomyolysis, the muscle breaking down. So yes, I know a statin will make you feel weak and muscle floppy, but still let us know so we can evaluate to make sure you're not going down the path of somewhere dangerous. So yes, we still tell them, please report to us muscle weakness, fatigues, and pain. And go. How many students participating when there's only 39 enrolled in the class?
On mine, it says there's only 31 participants. 34.
Yeah, that's how many have answered. 35 answered out of 40, but I only have 39 of you. Cool.
You're 40.
I'm not in. I'm the facilitator. It doesn't count me.
Well, maybe.
I know it used to freeze and make you refresh.
Oh, I wonder if that did it. Okay. All right. Which of the following is not a sign of digoxin toxicity? So what is my early signs? Yeah, abdominal pain, nausea, vomiting. What are my late signs? Those are my central nervous system signs, the weakness and fatigue. Yeah, that's heart failure anyhow. And then moving to vision changes, blurred vision, seeing halos around things. Is there a relationship between digoxin and potassium?
Yes.
What is that relationship? Yeah, they both want to compete for that same binding spot. So, would digoxin, does the drug impact potassium levels?
Yes.
Or
Potassium does digoxin.
potassium increases digoxin level, lack of potassium A lack of potassium, low potassium, will raise digoxin levels. Too much potassium will decrease. Will digoxin cause potassium to go high? No, that is not a true statement. Will hyperkalemia cause digoxin toxicity? Yeah. Hyperkalemia will do the opposite. It'll make the digoxin too low and ineffective. Now, hypokalemia may lead to abdominal pain, nausea, vomiting, and halos. Hypokalemia, low potassium, can lead to too much digoxin. But digoxin doesn't touch the potassium levels itself. Does that make sense? Cool. All right, those of you said that a non-selective beta blocker like propranolol cannot be given to somebody with pneumonia. Why are we saying that's a true statement?
Because it's non-selective.
Okay, so if it's non-selective, it can it can do something in the lungs, right? Okay. What can a non-selective beta blocker that can affect the lungs, what will it do in the lungs? It can cause bronchial spasms, right? Okay. Pneumonia, is that an acute process or a chronic process? Acute. That's an acute process. What happens with pneumonia in the lungs? Fluid. I'm not worried about fluid when I have bronchoconstriction. So it is perfectly fine to give somebody who has pneumonia, tell them to keep taking their propranolol. That is perfectly fine, because that bronchospasm is not going to be an issue. But is there a respiratory condition that the hallmark sign is random bronchoconstriction? Asthma. So yeah, I can give somebody with pneumonia their beta blocker, but if they are an asthmatic and are prone to just at random, their bronchioles going, it is not safe to give them a non-selective. Okay. COPD, sure, probably with a little caution. Pneumonia, perfectly fine. Bronchitis, perfectly fine. If they are an asthmatic, they cannot have a non-selective beta blocker. Now, can I give them the cardio-specific one or cardio-selective? Yes. What is that drug? What is my cardio-specific beta blocker? What's the prototype I told you to learn? You're right on the carbidopa level. What's the prototype one I told you to learn? You're going to see either that drug or propranolol on your test because those are your prototypes. What is it? Metoprolol. Metoprolol is my cardio-specific. There's like 1 million or so, give or take, beta blockers. They all end in LOL. And if you want to go work advanced cardiology, sure, know the entire list of cardio-specific and the entire list of non. But for testing purposes, I say know two. Know the one that is cardio-specific and know the one that is not.
So metoprolol.
Metoprolol is cardio-specific. Propranolol is not. My non-specific ones, like propranolol, will be contraindicated for patients who have asthma. And go. Cool. All right, following drug that will put a patient at a higher risk for hyperkalemia. So let me give you a hint on how to attack a question for like NCLEX purposes that you're like, I don't know. Try to narrow out the obvious wrong answers. Is there any relationship between beta blockers and potassium?
No.
No, so we can immediately, which is exactly what you did, immediately get rid of that as an option. I say, all right, digoxin. There is a relationship between digoxin and potassium, right? We just talked about this. But does digoxin increase or decrease the potassium?
No.
No, it doesn't. So I can get rid of that one. That left me with 3 options here. We've got hydrochlorothiazide, spironolactone, and furosemide. And then you'll go back and you remember, it's like, well, furosemide and hydrochlorothiazide, they're very similar. They do the same thing. One just does it a bit stronger. Furosemide, which is a loop diuretic, but I said we can give it another name, which is kind of a hint on what it does.
Potassium wasting.
It's a potassium wasting, which would lead us down the road to hypokalemia. And we just remembered that hydrochlorothiazide is very similar, just doesn't work as strong. So that can also lead us to hypokalemia. Now my spironolactone, an aldosterone antagonist, he said there's another word name that we can call him as a diuretic. Potassium sparing, meaning it spares the potassium, it keeps it in the body, which will lead to hyperkalemia. So spironolactone, the risk is hyperkalemia. In fact, any drug at all that will antagonize aldosterone or block aldosterone, the end result is a risk of potassium becoming too high or hyperkalemia. What is my normal potassium range, by the way? 3.5 to 5 for potassium. Okay, lisinopril on an empty stomach. First question, what drug class is lisinopril? It is an ACE inhibitor. Cool. Does lisinopril need to be on an empty stomach?
No.
Eat, don't care. Is there an ACE inhibitor where food matters? That's what I said. Here's your question. Captopril. What is the relationship between captopril and food?
You want to put the cap on.
Thank you. You put the cap back on the food and don't eat it. Captopril is my standout in that class. He's a hair different. That one has to be on an empty stomach. All of my other prills, I don't care if you eat or don't. Doesn't matter. If you eat, don't do it at Taco Bell because there's too much sodium there. Yes, it does. Yes, it does. She just said, does captopril also cause neutropenia? Yes, he does. What was your question?
Medication, I think. I might be getting mixed up with method, but is there one that's taken 2 hours before you eat and 4 hours after with antacids? Or am I just, did I read something?
Sounds
No, there was
familiar.
one specifically that said that it's 1 hour before, 4 hours after.
Yeah,
It's
that's
1
what I
before,
heard.
4 after. Anything in an acidic environment. Iron supplements. I'm trying to think if there was anything in this unit where I needed you to remember that, and I really don't think there was.
That was probably urinary then.
I think in this unit, there was nothing that I stressed that much. I will tell you, if there's any time there's a drug-to-drug interaction, you want to use that rule. Anytime there is a specific drug-to-drug where one thing is going to inactivate or superactivate the other one, most of the time if it inactivates it, keep space. But there's a couple of one of those I know in endocrine and the iron supplements in hematology form, but I don't think there was one in this unit. Okay. I may have just given it like glancing mention, but nothing that I stressed. All right, lisinopril you can take on an empty stomach. Lisinopril you can take it with food. Captopril, he matters. Food matters with captopril. Empty stomach. Alright. Which of the following is appropriate discharge teaching or patient teaching for someone taking hydrochlorothiazide? So hydrochlorothiazide, what type of medication is that?
It's a loop diuretic.
It's what?
It's a loop diuretic.
It's not a loop diuretic, it's just a diuretic. Furosemide is my loop, because it works in the loop. So it is a diuretic. Do we really want to tell my patient to take a diuretic at bedtime?
No.
That's just mean. No, when do we want them to take it?
In the morning.
First thing in the morning. It's going to make them urinate frequently, so you don't want to do that when you're trying to go to sleep. Should we ever tell somebody to expect to be fatigued? No, I mean, especially if my patient has heart failure and we're trying to reduce the afterload by getting rid of fluid, we should have that fatigue resolve. We don't want them to say, I'm going to feel worse on this medication. So we don't expect the fatigue. Does it matter with hydrochlorothiazide if we eat or not?
No.
It doesn't. If it causes GI upset, please eat with it. So that leaves us with salt substitutes. What do we commonly prescribe other than heart failure? What do we commonly prescribe hydrochlorothiazide for?
Edema.
If they have edema, I'm going to give them something bigger than that.
Hypertension.
Hypertension. So what's some good dietary teaching for somebody who has high blood pressure?
Oh.
Yeah, cut sodium. Cut sodium. So what did I tell you salt substitutes are made out of? Potassium. What's the relationship between hydrochlorothiazide and potassium? Yeah, we're going to lose potassium on that drug. So what's that?
Why would you need a salt substitute instead of eating iodized salt that has potassium?
Because it's not.
They're made
Salt.
of
Salt.
potassium.
Salt.
Yeah, but you're double potassium makes you sick.
No,
No,
it's
the loop-
the hydrochlorothiazide causes you to lose potassium.
Right.
Don't worry, they're
You're
correcting.
finding out salt to reduce the blood pressure with the hydrochlorothiazide, but it has potassium to replace what you're losing because of the hydrochlorothiazide.
Yeah, so if they typically salt the heck out of their food, and all of a sudden I say, don't salt your food, they're like, this tastes like garbage. Blech. Potassium chloride, no salt or salt substitute, tastes the exact same thing. So they're still getting that taste. And with furosemide and hydrochlorothiazide, it is perfectly safe to take that potassium fake salt and season their food with it. It is perfectly fine. One, because they're losing potassium, you can put it back in. Or if you don't like your food to taste salty, you eat anything on that list of foods. And I point that out because is there a diuretic where they can't take a salt substitute?
Yes.
What is it?
Potassium.
Yeah,
Yeah.
my potassium sparing, which is spironolactone. I'm going to tell them, because if they're taking spironolactone for hypertension, we're still going to talk about the DASH diet and sodium restriction. And they're going to go, ugh, my food tastes like garbage. I won't use the salt shaker, but I'm going to use no salt. No, you're not. That's not safe. But with furosemide and hydrochlorothiazide, yes, that no salt is perfectly safe that way. Okay. So whenever NCLEX, ATI, or I use the terms salt substitute, I'm specifically talking about that potassium chloride no salt. Okay, not like the Mrs. Dash and other stuff, the chemical potassium chloride. It is safe with hydrochlorothiazide. It is not safe with potassium-sparing diuretic. Okay, cardioselective beta blockers. They have more effect on the blood pressure.
No, it's the heart rate.
Remember I said beta blockers, both cardioselective and non-selective. They affect what more than the blood pressure? Heart what?
Rate.
Heart rate. Heart rate. Beta blockers have a stronger effect on heart rate. Now, if I can bring the rate down, that will potentially bring blood pressure down. But a beta blocker is going to affect the heart rate. They have minimal effect on blood pressure. What is my hold parameter for a beta blocker?
Less than 50. 50.
About 50 to 60, depending on which doctor is feeling brave enough. It's not going to slow the rate down as strong as digoxin will, but it's going to slow it down. So yeah, it's a good idea to monitor my patient's blood pressure. It is more important that before you give the medication, you know what their pulse is. All right, true or false? An ACE inhibitor will put my client at risk for hyperkalemia. So, which homeostasis system does the ACE inhibitor cut? What is it? Any medication that blocks or slows down the RAAS system will cause hyperkalemia. Stuff here, but let's draw this again real quick. So I've got liver, kidney. Those are not connected to the lungs. Stop it. Okay. That was a long list. We're dead. Clean that up later. All right, so remember the RAS system, which was much prettier the first time I did it. So if we've got ACE coming from the lungs, mixes with angiotensin 1, should make angiotensin 2, right? And angiotensin 2 does the things to the body which will vasoconstrict and will release aldosterone. Aldosterone goes to the kidney and brings back the sodium and kicks out the potassium. That is unmedicated how the body's going to work, right? Still with me? I haven't lost you on that.
No.
Okay, so if we block this system literally anywhere, my indirect or end result is eventually that Al is going to be blocked. No Al. If I don't have aldosterone, this doesn't happen. We can't retain sodium. So sodium is going to get excreted out of the body. It's going to be urinated out. But remember, we got to trade those two electrolytes. So if I can't keep sodium, what will I lose?
Potassium.
Potassium. So if I give an ACE inhibitor, like lisinopril, captopril, if I block the ACE inhibitor, can I make as much angiotensin 2?
No.
Which means, is Al going to get the message to go to work?
No.
No, he's not. Al gets blocked indirectly. So an ACE inhibitor working here in this, he says no, right here, eventually down the line will lead to hyperkalemia. What about my ARBs? What about angiotensin 2 retention, or the receptor blockers? What's that? What can they cause?
Should be
Same thing. Same thing. It blocks the change. It's in a different spot. What about my aldosterone antagonist, spironolactone? Same thing. What about a direct renin inhibitor? Same thing. Same thing. They are all eventually going to give my patient the risk of becoming hyperkalemic. I, honest to Pete, don't remember why I put that in here. But go.
This very reason.
Yeah, but the RAS system makes way more sense than nephron there. Okay, nitrate patches. So again, what would we give? Why would my patient be wearing a nitroglycerin patch or a nitrate patch?
Yeah.
Or what? Say
Stable angina.
So to treat or maintain stable angina. I said there is one big issue that we have with chronic use of nitrates.
Tolerance.
Developing a tolerance to them. And I said there's a workaround for that. We can try to prevent tolerance by doing what?
12 on 12 off.
Giving them a nitrate-free period, which is usually wear it for 12 hours, take it off for 12-ish hours. So no more than 3 hours a day does not give them enough coverage. Constant wear until we discontinue the prescription, we can just about guarantee they're going to become tolerant at that point. Wear it for a day, wear it off for a day. Well, what are you going to do on your day off? Not sit on the couch and do nothing? That's a valid statement. No, it's not. So if we wear it 12 on, 12 off, when's the best time for off?
When you're
sleeping.
Yeah, whenever you are doing the least, when your cardiac oxygen demand is at its lowest. So bedtime is the best time. Therapeutic digoxin level. You need to memorize this one. You need to know this one. This is very important. You need to know this. Not just for my test. If there is a drug that has a therapeutic level, ATI and NCLEX expects you to know it. The correct answer is 0.8 to 2 nanograms per milliliter. Okay, therapeutic digoxin or digoxin working as intended will decrease renal perfusion. You know, those kidneys are really important to us. We don't want to do anything to decrease perfusion or blood flow to those kidneys. So if something's therapeutic, it's not going to kill the kidneys. But that's a false statement. How does digoxin work?
Lowers the heart rate.
It what?
Lowers the heart rate.
That's one of his two things. He slows the heart rate down, and what's he do to the muscle?
Relaxes it.
Doesn't relax it.
Increases contractibility like strong muscle.
Exactly. Remember that positive inotrope means muscle go big, and negative chronotope means slows down. What's that? Yes, my goal is if instead of going squish, 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 we can just go big squish. We're going to have better cardiac output. We slowed it down, but we made the contraction stronger to get everything out of that ventricle, would give us better cardiac output. If my cardiac output improves, what would that do to my renal perfusion?
Should increase.
Yeah, it should make it better eventually. The drug doesn't work in the kidneys at all, but the end result should be we're going to save those kidneys and the brain and everything else that's important. Digoxin works to, one, make the contraction more forceful, but it's going to slow the heart rate down, which is not always a bad thing. Is there a hold parameter for the pulse for this one?
60.
This one, because it really does slow it down. If you have to. Before you give this medication to your patient, take their apical pulse. If it is less than 60, you do not give it. Besides blood pressure, what is the best way to tell if my dopamine is effective? So, what drug class is dopamine under? It is an adrenergic agonist, meaning it's going to mimic or supplement the sympathetic nervous system. What should it do to my blood pressure?
Lower.
It might raise it a little bit. What will it do to my heart rate? It should raise it a little bit. So it's both a positive inotrope, big muscle squish, positive chronotrope, big muscle squish, go fast. It also does one other thing that we really like it for, and it's why we'll give it in shock for a patient in shock or severe decompensated heart failure or shock. Outside of the heart, go a little bit farther south. I got two of them. Kidneys. What does dopamine do to my kidneys? Or at least the vessels in it? Dilates the renal vessels, which means I'll have more what? More who?
Urine output.
I will have an increased urine output. Dopamine. Not like it, sound alike, look alike, brother, but dopamine, in addition to raising heart rate and raising blood pressure and raising cardiac output, dilates the renal vessels, which will give me better urine output. Remember the crazy thing I said to remember this? If you smoke dope, we will know because we'll see it in your urine. The best way to tell if dopamine is working is an increase in urinary output.
We're doing great, guys.
And go. Thank you.
Yeah.
I was talking about my dad's friend Andy. They were down here and they're at breakfast. And
Yeah.
Dad's sitting there eating his cardboard and water and looks at Andy and he's like, Andy, what did you say? Your cholesterol is? It doesn't matter. I'm a statin. I'm going to enjoy my bacon and my eggs, my biscuits and gravy. I'm on a statin. It's fine. No. Medications are an adjunct to, an add-on to lifestyle modifications. So when they are taking their cholesterol-lowering drug, they still have to do the good things. They still have to diet and exercise. pain, not a sign of digoxin toxicity. Does this give you a hint that maybe you should really, really know your signs of digoxin toxicity? Yeah. Will digoxin overdose cause abdominal pain? Yeah, we start there. Will it cause a loss of appetite, anorexia?
Yes.
Yeah, it will. Will it cause vision changes?
Yes.
Yeah, it will. Will it affect the liver and make you jaundiced?
No.
No, jaundice is not a sign. What color does somebody's skin turn when they get jaundiced?
Yellow.
What color are the halos that they see in their vision usually? Yellowish white. Yeah. Don't get hung up. I was like, I remember something about yellow. But no. It is they do not turn jaundice. Their vision starts to get a yellowish hue and see halos. Okay. Calcium channel blockers. Apines. What are my two common side effects of those? Two most common side effects of my calcium channel blockers. Peripheral edema and reflex tachycardia. Calcium channel blockers. Edema and reflex tachycardia. Go. All right, a drug class that we will give with a calcium channel blocker to prevent the reflex tachycardia. So essentially, we want to give a drug that will slow a heart rate down, right? Name me a cardiac glycoside. If there is one in this class on your templates.
What was the question?
Name me a drug under the cardiac glycoside class. You can look it up or say it loud with confidence. Do y'all not have your templates in front of you?
Oh, no.
No.
Yes. I can tell it to you, but you'll learn it better if you look it up yourself. What is it? Digoxin is my cardiac glycoside. Does digoxin have an impact on heart rate?
Yes. Yes.
Yeah, it does.
Yeah, it slows it down. Are there significant side effects with it?
Yeah.
Is there a narrow therapeutic range I have to struggle to stay in?
Yes.
So is it going to be my first line choice?
No.
No. ACE inhibitors. Name me one. What is it? Lisinopril. Does lisinopril and all of its other ACE inhibitor buddies, do they lower heart rate?
No, they lower blood pressure.
They lower the blood pressure. My ARBs. Name me one. Or at least tell me his last name. Valsartan. Any sartan. Do my sartans. Angiotensin II receptor blockers. Do they lower my heart rate?
No.
What do they lower?
Blood pressure.
Blood pressure. So that's not going to work either. My beta blockers. Name me two. Metoprolol, labetalol, propanol, as long as it's a lol. Will it lower my heart rate?
Yes.
Yes. I mean, there's a few side effects, but there's no therapeutic window to stay in. So would we be comfortable giving metoprolol or labetalol or sotalol or propanolol to somebody on a calcium channel blocker to keep the reflex tachycardia from happening?
Yes.
And we do it all the time. Yep. contraindicated per administering amlodipine. So step 1. What drug class is amlodipine? P-I-N-E. What is it? It is a calcium channel blocker. So let me reword the question right now. Which is a clinical sign that would contraindicate a calcium channel blocker?
Somebody who's on a heart rate.
All right, so calcium channel blockers. Can they slow the heart rate down? It slows down conduction through the AV node, so it could. But how do I feel if their heart rate's 70? That's not any of my hold parameters, and also it's not going to slow it down enough to really matter. All right, what would we normally give calcium channel blockers for? Not my two weirdos, my everybody else. For what?
Hypertension.
Hypertension. 150 over 90, is that hypertension?
Yeah.
Do I like my patient with a blood pressure of 150 over 90? No, I maybe want to bring that down a little bit, right?
I thought it was
So the-
160.
What's that?
I thought it had to be 160 over 110. Or was that 180 over 110?
That's hypertensive crisis.
Oh,
That's hypertensive. This is just, let's get this down so that you don't go into heart failure. So the calcium channel blocker, like amlodipine, is designed to fix this. It's not contraindicated, it is indicated. I want to do it. Calcium channel blocker has 2 side effects. What are they? Peripheral edema and
reflex tachycardia.
reflex tachycardia. What drug class do we give to prevent the reflex tachycardia? Beta blockers, like maybe metoprolol. So if they're on metoprolol, go ahead and give them the calcium channel blocker. But the other side effect, other than the reflex tachy, is peripheral edema. Like maybe some swollen ankles. So if they are already exhibiting the peripheral edema, could it maybe be his fault? Maybe. Will this guy make it worse? Definitely. So that's my contraindication. That is also my patient teaching, that if they do start to note swelling in the feet and the legs, let your provider know immediately.
Mm-hmm.
All right, your patient took PDE5 inhibitor, which is a drug class to treat erectile dysfunction, things like Cialis or Viagra. They took it 2 hours ago. Bob and Betty were getting and he says, "Oh my God, Ethel, it's the big one." Why he said Ethel when he was with Betty, I don't know. Anywho, what can he not take for that chest pain? Nitroglycerin, a PDE5 inhibitor, any drug for ED taken with nitroglycerin will cause a life-threatening drop in blood pressure. Not safe. Y'all are going to make me proud on this one, right? You're going to do this. You're going to do this.
No promises.
We'll do our best.
What?
So half of us studied last night.
You all just hurt my feelings. Ezetimibe, comma, a cholesterol absorption inhibitor, comma, decreases the synthesis of... How does ezetimibe work? Knowing that the class is a cholesterol absorption inhibitor, tell me how it works.
It absorbs the cholesterol.
It doesn't. allow you to absorb the cholesterol from either what your liver made or what you ate. So, does ezetimibe limit the absorption of cholesterol?
Yes.
Yes, it does.
Hurt my feelers.
Cool. So even if you don't know the first guy, metonide, you should know the second guy, furosemide, goes by the street name Lasix, which says what drug class do they belong in? Or maybe you had 2 pop quizzes yesterday that asked you where in the kidney does furosemide work? In the loop of Henle, which is why it is a loop diuretic. It is not potassium sparing, they are potassium wasting. All right, which of these drugs puts my patient at the highest risk for hypokalemia? So, ranitidine, one, that's an H2 antagonist. It's a GI drug. It is also off the market. That is for acid reflux, GERD, so nope, don't care. Doxycycline. That's an antibiotic. Did we talk about antibiotics on this unit at all? No, we did not. So that gives me a 50-50 shot. We only talked about 2. We talked about furosemide, we talked about spironolactone. And when it comes to their relationship with potassium, they're exact opposites, right? One holds it, one gets rid of it. Who is who?
Spironolactone.
Spironolactone is a potassium sparing, which puts them at risk for which imbalance? Hyperkalemia. Furosemide is a potassium wasting diuretic, which puts them at risk for what potassium imbalance? Hypokalemia. Okay. So I've got to stress again, as you are studying, understand each drug class's relationship with potassium. Is it going to make the body hold it, or is it going to make the body lose it? You also need to understand the relationship between potassium and digoxin, which I think you guys have got. Okay. So for something to put the patient at risk for digoxin toxicity, what has to happen to the potassium? For the digoxin levels to rise and become toxic, potassium's going to drop, right? So then the question is, which one of these drug classes or drugs is going to decrease potassium? Okay. Acyclovir. Did we talk about any antivirals?
No.
Nah, it doesn't count. So that gives me an ACE inhibitor, a loop diuretic, and an aldosterone antagonist. My ACE inhibitor and my aldosterone antagonist, like spironolactone, do they both work here in my RA system? Which means if it works to break this system, what's going to happen to the body's potassium levels? They're going to rise. So both an ACE inhibitor and spironolactone will cause potassium to go up, which means digoxin levels cannot go toxic. That leaves me with only one option. My potassium wasting diuretic. That's my furosemide. Okay, so medication group blocks the formation of angiotensin II, which means my adrenergics, they're out of the picture altogether. They don't work in the RAS system. So the beta blockers aren't going to do it, and my alpha-2 adrenergic agonists aren't going to do it. Those two classes work in the sympathetic nervous system, not in the RAS system. So that gives me my angiotensin blockers, or my angiotensin II receptor blockers, or my ACE inhibitors. So we go back over here and look at how things work. Again, we've got renin mixing with angiotensinogen, which makes angiotensin 1, right? That's an ingredient. He doesn't do anything. I need another ingredient to get to 2. What is that? Angiotensin converting enzyme. I need him to make angiotensin 2. Blocks the formation of. Meaning, without him, I can't form this. Make sense? My angiotensin receptor blockers, we can make angiotensin 2. We've got it. But we blocked his receptors, meaning he exists, but he can't go to work. We blocked him from going to work. Road closed. But I can't make him. He can't exist without ACE. So ACE inhibitors block the formation of angiotensin 2. So we've got a group of medications that will vasodilate, but it doesn't work on the receptors in the periphery. This drug class works specifically in the central nervous system to shut down the sympathetic nervous system. It works in the brain rather than all the peripheral receptors. So my beta blockers, they work in the periphery. My calcium channel blockers, they work by blocking the calcium channels in smooth muscle. Doesn't affect the central nervous system. My direct renin inhibitors, they work in the kidney by telling it not to spit out its renin ingredient. But my alpha-2 adrenergics, no, it's an agonist, and peripherally they'll constrict. In the brain, it tells the sympathetic nervous system, no, simmer down, push. Relax those blood vessels. Relax that heart rate. Relax everything. Alpha-2 adrenergic agonists work in the central nervous system. What? Yes.
So the ABCD thing.
It doesn't apply in the central nervous system.
I was just talking about blood vessel dilation and constriction.
Or even smooth muscle dilation and constriction.
So the beta blockers would be constricting if
They're dilating.
Yes,
Or-
a beta
yeah, B
blocker
goes
will
with
cause
D.
them to dilate.
So what
Except
are
a
the
beta
alpha
blocker will
ones?
make them not dilate, but that's okay because we want to touch the heart rate with them anyhow. The ABCD, alpha receptors constrict, beta receptors dilate, that exists from like here down. Not in the central nervous system. Not in the central nervous system. This is one of those ones where you just kind of have to memorize. So what is my drug here? What drug would I put in this class? That's an ACE inhibitor. I gave you a C. Dopamine is an adrenergic agonist, but it's not centrally agonist. Oh, you're thinking catecholamines, which is what our body normally makes, which would trigger the sympathetic nervous system. This is a drug that starts with C. Methyl-dopa is another one. It's a little on the sedating side. We don't want our patients to have alcohol with it. It is what? It is clonidine. What the? Oh, no, don't label that one. That one is clonidine. Group of drugs that will decrease the heart rate, which is what it does the best, but it also kind of makes the heartbeat not quite as strong. Pure memorization on this one. ARB, angiotensin receptor blockers. Does it affect heart rate?
No.
Nope, we get rid of that one. Calcium channel blockers. Some of them can affect the heart rate. Does it do anything with the contractility? Maybe this much, not enough to matter. My alpha blockers. Did we talk about alpha antagonists?
Well, we
talk about
have, but
alpha
not in
agonists.
here.
So it's not them. It's not them. Alpha antagonists, they work in the sympathetic nervous system. But my beta blockers affect what? More than what?
Heart rate, blood pressure.
Heart rate and blood pressure, because it slows the heart rate down and it tells it not to beat quite as hard. Is there any maybe very common cardiac condition that we would want to use these with caution?
Sinus bradycardia.
If they're in sinus brady, they're not getting it.
CT.
Chronic cardiac condition. Very common in the elderly. About 65% of diagnoses for elderly. Has a low ejection fraction. In the early stages, it could cause lung issues. Late stages, it could cause some JVD, some ascites, some peripheral edema. What is it? Heart failure. Yeah, in severe heart failure, we'll use a beta blocker, but with extreme caution, because not only is it going to slow the rate down, it's going to slow the contractility down, and there's a minute risk of decreasing cardiac output. Yeah.
Would this be kind of contraindicated or at least watched? Does somebody have like prolonged QT wave as well?
It does not affect the QT prolongation.
Okay.
We watch the PR interval, and even a beta blocker is not going to slow it down enough to throw them into a heart block. But no, this is not one of my many QT prolongation drugs. The only time this one, watch the PR interval, but again, it's not going to make a difference. My calcium channel blockers, what's your PR interval? Zofran QT. What was there was one drug in this unit we talked about, and it barely got much of a mention, that does cause QT prolongation, and you don't have a template for it. It's for dysrhythmias. It's also an antiparasite. What is it? Quinolone.
Yeah.
Quinidine. Quinolone, quinidine. I can't remember which is the old one, which is the new one. That was the only drug in this unit we talked about QT prolongation, and you don't have a template for it. Your mom. Nice. Okay.